So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. Hello and welcome back to our second episode on cognitive processing therapy. To hear the full bio, you can go back to our last episode, but we have Dr. Patricia Resick, who is the developer of cognitive processing therapy. We had just did an episode more so on trauma and PTSD, and now we're going to be looping in more about the nitty gritty on cognitive processing therapy. But before we get there, you had mentioned that you were on the DSM-4 and 5 committee for PTSD. And one of my interests is how well is the DSM doing? Is there any limitations? Because we're always evolving. That's why we're on the 5th edition. And anything that you think that could be bolstered in the DSM diagnosis of PTSD?
Well, things remain to be seen on how well it works. I mean, they're already starting to do factor analyses, and they don't come up with the same, just like the last time with the DSM-3 and 4, we didn't come up with the same criteria as we did this time, and so we were trying to correct for that. But they'll do a factor analysis and they'll come up with different factors again. So I'm sure it's going to get changed again. The one thing that I think we have never paid enough attention to was the effects of neglect and child emotional abuse, or any kind of emotional abuse, I should say. We often think about trauma as being, like physically dangerous, and which is, part of our definition of trauma. But I think we need to study more about the effects of neglect and the effects of emotional abuse on development, and then how trauma intersects with that. Because I think the people who've had those kinds of experiences are going to have worse trauma reactions later, because they're going to have a certain headset and belief system.
So you're saying more that it is the emotional abuse and neglect as being a triggering event, or you mean more so it sets up their belief system, which makes them more prone to developing PTSD?
I think it probably sets up their belief system. We just don't have, we haven't studied it enough, so I don't know where we are with it. I mean, I'm sure there's some bright young researchers out there who really could suddenly get a light bulb and say, hey, we need to be studying this. But I think it's an understudied topic, and how it relates to PTSD, how it relates to treatment as a predictor of treatment outcome, and so forth.
Well, if you're a researcher and you're listening now, you might have a new dissertation or a grant proposal on your hands. The concept of post-traumatic growth, and then we'll jump into CPT. What is post-traumatic growth, and is there a way to promote it to be more effectively, like to occur more, or to promote it, I guess, if you will?
I think my own opinion.
Yes.
I looked at it with one of my former graduate students who's faculty now, and we found it to be independent of PTSD. You can have post-traumatic growth and you can have PTSD at the same time. I think the idea that people had was that if you had post-traumatic growth, you wouldn't get PTSD, and I'm not sure that's the case. I think that's why psychologists can get PTSD just like anybody else, even though they know what the symptoms are. You're going to have that reaction to things. So I think post-traumatic growth might be more of an end point than as a preventative or as a treatment for PTSD. And I've seen people with terrible PTSD who say, I really appreciate what other people go through now. Well, that's post-traumatic growth, but that isn't stopping their PTSD from happening.
Yes.
So I think they're just like two different fields, and you want people in the end to have grown from their experience and maybe have more balanced beliefs. I mean, that's what I would have as an outcome for the CPT anyway, that they're going to have more realistic, more balanced beliefs about themselves and other people. And I would define that as growth. But that's treating their PTSD. So we could measure post-traumatic growth right along with it, but I don't think that's a preventative.
Yeah, and if you're helping change a belief system that's making someone prone to PTSD, and we're reducing that, then they're getting fortitude and growth to prevent
Right.
that from happening potentially again.
Right. And there was a lot of research going on in the military for a while on resilience and stuff, and thinking if people had more resilience, they wouldn't get PTSD. And that was an abject failure after spending millions and millions of dollars. They still got PTSD.
Oh, wow.
Because they didn't like the concept of people getting PTSD. They wanted to really foster resilience, but it really didn't make a difference.
How are they fostering resilience?
Oh, they had these programs. It came out of Seligman's lab. He did a study with undergraduates, and then the Army just jumped all over it. They're still doing it, even though it doesn't. Any research on it has shown that it doesn't really prevent PTSD.
Interesting.
Hardiness. I mean, those are concepts that you hear about.
All right, so let's jump into CPT itself. I know that there's like two main protocols or versions of them. What are the two versions, and how do they differ?
Of CPT?
Yes, of CPT.
Well, actually, there's more than two now. There's probably about 4 or 5 versions of CPT now.
Okay.
Well, here's my case for this, and why it keeps evolving, is that in medicine, it takes about 17 years, which is outrageous to think about, to get some medicine studied, shown to be effective, and then get it into usual practice. We are now on 38 years of treating PTSD, and doing evidence-based treatments is still not usual practice.
And very, very effective evidence-based treatment.
Oh, yeah.
Too.
Oh, yeah. And so what we have to do is try to figure out how to make it more accessible, more acceptable, more efficient, so that people are more likely to use it. And then, of course, there's all the dissemination and training efforts that go into trying to get it out there into the world with therapists. You know, they need to be learning about this in graduate school, and learning how to practice with these kinds of therapies. But it's unfortunate that it's taking a long period of time. But okay, so back to the different formats. We started out with CPT that had 2 written accounts. And so because, you know, PTSD was listed as an anxiety disorder in the DSM in 1980. And so they thought that there might be some need for the exposure to the actual trauma memory, and to read it to themselves. I did a written version of it. In PE, they do repeating the account over and over again, and then doing behavioral exposures. And the idea was that you'd habituate to your fear, because it was considered an anxiety disorder, a fear disorder. And a lot of the research was about fear circuitry. Now, we've discovered there's a whole different circuit for people who didn't have fear during the trauma. But I didn't go that direction in the beginning, because I was working with rape victims who, not always, but very often, said it wasn't the fear of it. It was the fact that I didn't think he was going to kill me. It was my ex-husband, my boyfriend, whatever. But what he did was so humiliating, so degrading. And I felt so betrayed. And they're having a whole different reaction to the event. And so I started leaning more toward the cognitive therapies, because I thought we could get to the fear and to the other cognitions and the depression. And, you know, half of people with PTSD have major depressive disorder. So I started looking at Aaron Beck's work. He had already done the treatment manual for depression, and he had just produced a manual on anxiety. And I thought, this may be the way to go, so I can hit these symptoms. And so I did, you know, when I developed CPT, it had 2 written accounts that they would write between the sessions, read it back to the therapist. The therapist would listen to it, do Socratic questioning around their stuck points, which had already been predetermined with an impact statement. And when I got to the end of that study and compared it to prolonged exposure, there was no difference in PE in the PTSD. And they said, well, it's just because you did the written accounts. So then I did a second study, a dismantling study, where we did full CPT, and we did a version that had no exposures, no written accounts. We just did more. ABC sheets and more Socratic questioning, and then we divided one of the other sessions up later, so it was the same. And then we did written accounts only, and the one that did the best was cognitive therapy without the exposure, the written exposures. They ended up the same, but when you looked at what was happening at the time, there was a clinically significant drop by session 4, and it took them 2 more sessions to catch up. And it was after they got done doing the written accounts. And then it wasn't statistically significant, but there was a 15% higher dropout rate when they wrote their accounts. That's when they were, if they didn't quit before the therapy started, that's when they were most likely to quit, was when it was time to write their accounts. So when we wrote the manual in 2016-17, we made the main part of the manual without the written accounts, and then put the accounts in as a back chapter, because like in the VA hospitals, they'll give people a choice. Do you want to do it with or without the accounts? Because it ended the same. There's no value added by doing the accounts, but it didn't do worse. It just takes you a little bit longer to get there. So we were, most of the studies I've done since then have been without the accounts. The only exception to that, I think I already mentioned in that last segment, was with the high dissociators. They seemed to need to do the written accounts. They did better with the written accounts. Low, medium dissociators, no dissociators do better with the CT. But the ones with high dissociation did better when they had the full protocol with the written accounts. And I think it's because they had to get those fragments back into a beginning, a middle, and an end, and then the therapist could do the cognitive work easier, because it made more sense then.
Yeah.
So anyway, so we've been doing that. Now I just said that we've got other versions. The next thing that came along was variable length. Tara Golovsky was working on the dismantling study, and she came to me and said, if I just had a couple more sessions, I'm sure I could have gotten that guy around the corner. So I made up 12 sessions. That sounded like a good number when I first started doing this.
That's research.
It's not magic. I just made it up. I could fit everything in, and I was doing it as a group treatment to begin with. So you had to have and often you'll see it as a 12-session protocol, because you're comparing it to something else, and so you do 12 sessions. But she said, well, what if we do, and so she did have a control condition, but so it was a randomized controlled trial, but she let them either stop short or go up to 18 sessions. And then wanted to see not just did they lose their PTSD diagnosis, but did they get to a really good end state, really low scores. On the BDI, they had to be below a 10, so really not depressed. On the PDS, which was the self-report scale they were using at the time, and the Edna-Foy scale, below a 20. Now on the PCL 5, now it's below, 19 or below. Good end state. So she found out that 92%, if they had a varying length, in other words, a flexible length therapy, they got to a good end state. There were very few people that didn't recover in 18 sessions. About 58% actually ended early. They averaged about 9 sessions. So again, 12 was not magic. There was a few people that did 12, and then there was about a little more than a quarter of them needed extra sessions. So we just changed the protocol. If they look like they're not recovering as well as you'd like them to be, and it's probably what happens in clinical practice anyway, you just don't have them write their final impact statement. You just keep working with the worksheets and their stuck point log and help them, really get turned around the corner on whatever it is they're stuck on. Maybe it's a different trauma. Maybe it's something they left out of the trauma or didn't want to talk about before. It might be that there's a stuck point underneath the stuck point that's keeping them held. So sometimes there's all sorts of, a big schema that they've had. So they might need a few more sessions. But a lot of people are actually ending early. The other thing that happened was that Cassidy Gutner, one of my postdocs at the time, looked at my first 2 studies, and we were doing the CPT twice a week for 6 weeks, 12 sessions. And she looked to see if, and that was with both of those studies, and she wanted to see if people dragged it out longer, if they did worse, or if they did it in that length of time. Because, people no show on sessions, they're sick, they go on vacation, the therapist has to go to a conference, so sometimes things don't happen twice a week.
Mm-hmm.
So she looked at it and found out that the faster that they did, the shorter number of days between sessions, the better the outcomes.
Wow.
And then the next thing that came along then was starting to do it as a mass treatment. So that's the next adaptation. I think Craig Bryant was the first person who started doing that. And he was actually doing it with special forces people who didn't want to go to the military because they didn't want to lose their clearances. And so they would take vacation with their family, and they would go to Utah, which is where he was at the time. And they would get sessions every morning of CPT for 2 weeks, basically, and go skiing or hiking with their family in the afternoon. Then when Craig moved to Ohio State, he was also still working with veterans, but he said, okay, well, how about doing it where you do a session and you go to the gym and do exercise every afternoon? And then he had another condition where they didn't do exercise, they just did the CPT. And then another one where they just did it once a week, like people often do. I always do my research with twice a week, but the VA does once a week sessions, and I think that's a real mistake, because you're dragging it out too long. So he found out that doing it short was definitely better than doing it once a week, but he also found out the exercise made no difference whatsoever. The group that did the best was just the CPT only. And then Philip Held at Rush in Chicago started looking at a 3-week program that was kind of a residential program, and they had all this other stuff on top of the CPT, and the people who got it said it's the CPT that was the best part. So then they moved to, and they were doing all sorts of things like assertiveness training and mindfulness and all sorts of other skills kinds of things and affect regulation kind of stuff. And they said it was the CPT when they got the feedback. So they moved it to a 202-week treatment. And now he's testing a 1-week treatment. And one of my colleagues, Jennifer Watchin, is writing it up for publication now, but she actually went to Fort Belvoir and compared a 1-week treatment, group and individual. They got all 12 sessions in 1 week. They just took a week and compared it to doing it twice a week for 6 weeks. 5% dropout rate when you do it in massed, and that's exactly what Craig and Philip Held also found. Very low dropout rates, no differences in outcomes. They do just as well in treatment. So I'm a big fan of doing it fast as you can now. I mean, when you think about how hard it is to drag therapy out over a period of months, driving your car somewhere. I mean, we've also done studies where we looked at in-home versus where the therapist actually goes to their house, or do it on telehealth, or do it on come to the office. And coming to the office had the highest dropout rate. It was up to 44%. You're asking people to do a lot. You're asking them to drive somewhere, find parking, and we even actually had a good situation in that study. Parking didn't cost anything. It was right off the highway, lovely office building. Still had a 44% dropout rate when it was in person. Life gets in the way. So I'm a big fan of variable length, and I'm a big fan of doing it as fast as possible.
Okay, so shrink it and do it for as short or as long as it's needed for it to get the effect, because we're going to probably get there.
Yes, with a lower dropout rate.
With a lower dropout rate. Wow.
Yeah.
That's amazing. Yeah. So when we're looking at the nuts and bolts of CPT, what are the main areas? So we're doing like psychoed, we're doing the impact statement, we're looking at cognitions or safety themes. So kind of just trying to orient people to if they were going through or they were providing a course of CPT, what would they actually be doing?
Okay.
across
Yeah,
sessions.
yeah. After they're assessed and they know they're coming in and they do have PTSD, they go right to work on immediately. We don't have a phase-based system. They go straight into CPT, which means they get psychoeducation. They understand what interferes, and they start working together to figure out what's interfered, what stopped them from recovery. We consider this a recovery model that's gotten halted for some reason. So we got to figure out what stalled out their natural recovery. Something's in the way. And we think of that in terms of what they're saying themselves and their avoidance kinds of things, and talk to them about not avoiding. And then we're going to work on the cognitions, letting yourself feel the natural ones and doing the cognitive work on the ones that are secondary to what you're saying to yourself about the trauma. So they write an impact statement. Why do you think this trauma happened? That's the first assignment they get after session 1. And why do you think this event happened? And then how has that affected you? How has that affected your beliefs about yourself and other people in these theme areas: safety, trust, power and esteem, control, and power, esteem, and intimacy. And those came from Laurie Perlman. And, when I was first developing CPT, those did seem like those were very disrupted by PTSD. I'm sure we could come up with some other themes as well, but they're very Maslow hierarchical. We start with basic safety and work up to intimacy, self, and other. So they do a session of each on those if they need them. Now, if you're doing variable length, they may stop before that, and you just hand them the modules and they look at it and see if there's something they want to spend time on. We use a real simple ABC sheet: an activating event, a belief, and the consequence, the feeling that they have. So this event happened to me. I was assaulted. It's all my fault. I feel guilt. And then the therapist could go in and start doing some gentle Socratic questioning. Well, how is it your fault? Well, I should have blah, blah, blah. Well, how could you have known that? The Socratic model and the style is all the way through here. So we don't argue with them. We don't say it wasn't your fault, because you're going to lose the patient. What do you know? You weren't there. Must be my fault. So you don't get into an argument with your patient. What you're doing is asking them questions so they can figure out that it wasn't their fault, or that they couldn't have stopped it, that it happened in spite of them, not because of them. So you're going to be asking Socratic questioning. So we do the ABC sheets for a couple of sessions, just teaching them the whole process of understanding when an event happens, you have a thought about it. If you had a different thought, you might have a different emotion. And then the next time you do it, you're doing it all on the traumatic event. And if you can figure out what their linchpin stuck point is, sometimes it's like that game of Jenga. If you can figure out which one to pull out, the whole thing kind of tumbles. So you're looking for the linchpin. It's all my fault because X. And once they realize that they couldn't have stopped it, then all their other stuck points start collapsing around it. So we have them do that. Then we start actually handing the therapy over to them. We start teaching them to ask the questions instead of us asking them. So it used to be called the challenging question sheet. In the new manual, it's going to be called exploring questions worksheet. I'm getting rid of the word challenge all over that. Okay.
Yeah.
Because
it's a better phrasing.
And that came from the original materials that I was getting this from. But the word challenge could be looked at in a benevolent way, but often it's looked at as more adversarial, and they throw the therapist on the other side of you being challenging them. And what we're trying to get is them to challenge themselves. So we've changed all the language. That you won't find the word challenge in the new manual. If I did good enough, if the three of us did good enough proofreading. So they would pick out a particular stuck point and they would answer questions. Now we're revising fewer questions to ask themselves. And then the next worksheet there is called thinking patterns now. It's not called problematic thinking patterns or faulty thinking patterns or anything like that. It's just called thinking patterns because we have a tendency to think in certain ways. Jumping to conclusions, mind reading, Emotional reasoning. I feel fear, so I must be in danger, so I better run away. And then you never, of course, disconfirm your idea that you were in danger. I feel guilty, so I must have done something wrong. So that's emotional reasoning. So there's a series of those. You say, are you doing one of those with this stuck point? And then finally they get to the final worksheet, which is now called the alternative thoughts worksheet, not the challenging beliefs worksheet. And it's got everything else in it. It's got the ABC worksheet on it, except we have them rate how strongly do you now believe that, and how strongly do you feel whatever your emotion is. And then they ask the questions to themselves with the exploring questions. They check and see if it's one of their tendencies in terms of thinking patterns, and then they have to come up with an alternative thought. And that's where sometimes the therapist really has to get involved and help them. The seeds is usually what's the evidence against your thought would be the seed for coming up with an alternative thought. And the therapist just wants to make sure it's a good one, that's not going to make them still feel like they're in danger. But more balanced thought that's going to have them feeling, different. And it doesn't necessarily mean they're going to feel great, because if you blame yourself because somebody else died, there's a house fire, and you couldn't get back in and save your brother, and you're blaming yourself, and you've been feeling blame, shame, guilt all this time. What we may be getting you to at the end of all this process is grief. We're not trying to get people to happy. We're trying to get them to realistic, accepting the event that happened and feeling their natural feelings about it. So they may go from blaming themselves to feeling angry at the perpetrator, and then that needs to run its course. But the idea is to have them thinking in a more realistic way, not a Pollyanna way, and then feeling whatever naturally they would be feeling under those circumstances. Then maybe they didn't let themselves feel. So that's kind of the basic setup. It takes 12 sessions, and then those last 5 sessions we're going through the themes along with whatever stuck points they happen to have.
And there's a different process between feeling your adaptive. I think you call them manufactured, natural versus manufactured, or I might be getting the terms wrong.
No, we call it with clients, we call it manufactured, because we're saying you've got a little factory in your head. The example we'll sometimes give is that emotions are like a fire. You're sitting outside and there's a fire burning, and you just sit there and watch it. It's got a heat, it's got an energy to it. You got to stay a certain distance from it or you're going to get burned. So you're going to sit back and watch it. And then what happens eventually? Well, it burns down and becomes ash. Yeah, that's what natural emotions do. So a natural emotion is one you don't have to think about. If I'm standing at the top of a tall building with you and I'm pushing on your back, your natural emotion is going to be to feel fear. Hopefully, I'm pushing. And then if I back off and go, kidding, then you turn around and what's your natural emotion?
I mean, probably frustration and relief.
Or anger.
Anger,
How dare she do that to me?
Yeah, maybe I'm too nice. And also learn not to go on the top of a building with you.
Yes, exactly. But that's a lot more thinking. Your natural emotion probably would be, how dare you do that? Okay, so that would be a natural emotion. All right, when you're in danger, you feel fear. If somebody's trying to harm you, you naturally feel anger. When good things happen, you feel happy. You don't have to say, "Oh, I'm happy. I should feel happy right now." It's a pleasant sensation. When you have losses, you feel sad. Those don't have to have thoughts in the middle of them. Now, some things like anger can. Anger gets used all sorts of ways. Anger can be a natural emotion. It can be manufactured. You can be angry at the wrong person. You can be angry at yourself because of the way you thought it through. Okay? And some people use anger to push people away. So their automatic go-to is like, I feel like I'm in danger when I'm around these people. So if I push everybody away by being angry and grouchy all the time, then they'll stay away from me and I'm safer. So anger is one of those interesting ones that has lots of functions. But so it could be natural, it could be manufactured. Now, the manufactured emotions, you're sitting there looking at the fire and you're throwing thought logs on the fire. It's all my fault. I should have done this. I should have done that. And the fire gets this blazing fire there because you keep thinking these things that keep the fire going. You never get to those natural emotions because you keep throwing on logs that are thought logs. If we take that fuel away, fire is going to die down. So this is the cognitive therapy part, is taking those thought logs away, and instantly it's going to be, the fire is going to get less and then burn down naturally. So that's the example we would use with them, that the natural ones are just going to burn down naturally. The manufactured ones, the ones that are produced by the factory in your head, are the ones that are going to be needing some cognitive therapy. And you pull that thought away and change it, it's not going to keep flaming there for forever.
When you address the manufactured emotions through the stuck points, and now say that they are grieving now because now they're feeling sad because they like in that example he gave, he did lose his brother in the fire, right? Do you just have the person leave treatment because it will be a natural healing process, or do you stick with them and do something?
Well, you would see if they had any stuck points about, like, I shouldn't feel grief after all this time. I mean, people will have stuck points about their grief too.
Sure.
So you'd be looking to see if they had, but you might space out if they're having a normal grief response. Grief takes a while, so you just want to make sure they don't develop prolonged grief disorder. And that they're having they're finally allowing themselves to grieve. And that may not take that long. So you might want to have a few more sessions. You might want to see them in a month and see how they're doing, but you want to make sure they don't have any stuck points about the fact that they're grieving now after all this time.
Mm-hmm. And where are we finding the stuck points? Because I know you talked about like the impact statement. We have worksheets. Where are we?
That's
finding
where you're
these
finding
to
them.
help clients?
You're finding them to begin with the initial impact statement, which you're hoping is at least a page long, handwritten. And you put those onto the stuck point log. You spend the whole session kind of thinking about, well, that sounds like a fact. Let's leave that one there. But this one sounds like a stuck point when you say it's all my fault. Or if they say it's my fault, then I might say, are you saying it's all your fault? Let's put the word all in there. Okay. Or if they say, I can't trust anyone, I might ask, if you trust someone, what will happen? So I like if-then statements because you've got two sides of that equation to work on. If I trust people, then I will be hurt. Or if I trust people, they will betray me. If I trust people, then whatever, I'm in danger. So there's two sides to that statement. So then you can get into what do you mean by trust, and then when we hit the trust module, and you can also talk about possible consequences. But a lot of those come out in the Socratic dialogue that you're doing back and forth with them too, because they'll start throwing out stuck points, and it's kind of like, but it is my fault because of X. Oh, you didn't mention that one before. Let's get that one down on your log. So the stuck point logs are kind of a living document that you can cross things off if you don't believe them anymore, but you can keep adding to them as they come up in therapy or as they're writing their assignments. Sometimes they'll put them in the worksheets and you realize, no, that's just another stuck point. It's phrased differently, but it's still another stuck point. It's another thought that's keeping them stuck in their PTSD.
Will you rewrite the impact statement after you go through all the stuck points?
Yeah, at the end of therapy, after they've gone through and you've got a nice low score, if you're doing variable length or if you're doing research or you're stuck with doing only 12 sessions, the last session they would rewrite their impact statement. And you say, now, what do you think about it? Now, why do you think it happened? And now, how do you feel about safety, trust, power and control, esteem, intimacy? And then we would finish off by saying which ones, they read you their impact statement. I would read them their first impact statement. They go, wow, did I really believe that? That's always a very fun session because they'll be shocked at what they used to say to themselves. And maybe it was only 6 weeks ago. So then you look and see if there's any they still need to work on. It might be esteem, it might be intimacy, and so you might give them a fresh stuck point log. Sometimes people will come up with an alternative thoughts log that they need to practice. I mean, sometimes when people are older and they tend to go back to that old thought they had just because they've had it for 40 or 50 years. Sometimes when we're working with the elderly veterans, we might put stickies up and have them put it up on the mirror so they have their alternative thought they can practice saying, or ask them to reread a good worksheet that they've come up with, so that it gets to be more of the path they take instead of the one that leads them down into the muck.
Yeah, and yeah, because you might rationally get it, it might take time and rehearsal and repetition,
And it's
repetition,
really
repetition in order for the new
it's
pathway.
really common to hear people in the middle of therapy saying, I hear what you say and it makes sense, but I don't feel that way. And I was like, well, your feelings haven't caught up with your, because it's been a habit to say this so long that your feelings haven't caught up. So you've got to repeat this enough times that this becomes the new thought that is your go-to. It's the other one hasn't gone away. You just got to use this one more and believe it. And so you might need to do some more worksheets so that you believe it more, collect more evidence.
The themes that you were talking about, safety, trust, power, control, esteem, intimacy, are you interweaving that throughout the sheets and as you're working through it? Because I know at the end you say, there are days aligned for that. Is it that you're working on like stuck points and then that unlocks you to be able to work on these other themes, or are you interweaving these themes
It
throughout
would
treatment?
depend on the stuck point and the theme. Now, when we're doing the group treatment, that's why I had them go through all of these. Sometimes people don't need to go through every one of those themes; they don't have any issues with one of them. But sometimes, if somebody's got like a whole lot of control issues, they've got OCD tendencies, or they drink, or they, like you wouldn't want to get working on that to begin with. And so you would weave that in throughout and then really focus in on that when they get to that. Like if I'm not in control, I'm totally out of control. And so I might as well just be totally out of control and be drunk. You know, you don't want to wait till session 8 to get to, or 10 to get to that. You want to have them working on that earlier and seeing that that's been one of their avoidance strategies. Or if they've got an OCD that's particular to their trauma, checking and rechecking their house, or driving back to check and make sure they lock the door. Or maybe that was yesterday, um, or washing and washing and washing. I mean, sometimes you can see there's just a clear link back to the trauma. You might want to bring that in earlier and have them understand that those are avoidance behaviors that they've been doing and trying to change some of those habits, or instead of going back and checking their house, doing a worksheet on it. Pull the car over, do a worksheet. Is there ever been a day you didn't lock the house?
Turn around and keep going.
No, don't turn around and go look.
You had mentioned last episode about the assimilation and the over accommodation style cognitions. Is that something that you're teaching clients about? Or
we don't use that terminology with them. That's for the therapist, because they need to know they need to work on the assimilated stuck points first. I mean, we've got several research studies that have shown that better outcomes if they work on the trauma. That means going back and working on the trauma in their assimilation, how they've distorted their beliefs about what happened to fit the just world, say. So it's important to do, or the hindsight bias, or whatever it happens to be, that they're going back and working on the trauma itself first, then the over-accommodated ones come later, and they're easier to deal with. It's tempting to do that early, because if somebody says, oh, I don't trust anybody, your inclination is like, oh, let's work on that one. Is there anybody you can trust? Babies, grandmothers, your second grade teacher. And then you just don't get anywhere, because first of all, it's too big a concept and you haven't really taught them the skills yet. So you
Mm-hmm.
want to start at the beginning and teach them the skills of how to look at their thoughts and work on the trauma itself, because some of those are going to start naturally falling apart. Well, if it didn't happen because of this, then why am I scared of blue trucks now?
Yeah. They'll a lot of them will naturally dissolve just because they just don't make
or
any rational sense
right,
anymore. Logical
and
sense.
very easily challenged then. So yeah, I think safety can be a tough one to work on. And you said, the example of, like if there's 1,000,000 and 1 chance that it could happen, I'm not going into a parking garage. I had one woman who worked at a university where they would always post anytime there's a crime going on or this happened. Okay, you've been working at this university for 20 years. How many times have there been assaults in that parking garage that you work in? She looked it up. Never. So why are you taking your keys and running to your car every day as if you are
Mm-hmm.
in imminent danger? Okay, what would happen if you strolled there? What are the probabilities? And like, what is this doing to your system when you're so anxious? And so we talk about, why is it important to stay calm? You'd be better off being calm than being scared. If you really were in a situation, you'd be able to keep your head about you if you were calmer.
Yes.
Okay. So,
Um, I'm thinking about the Warriors fallacy where Bob Leahy said to me once, "Do you think you'll handle a stressful situation better if you're cool, calm, and collected, or if you've been worried, stressed out, and probably haven't slept very well?"
yeah,
And yeah, the answer is probably cool, calm, and
collected.
collected with your head about
Yeah.
you. Um, so you using the CPT protocol, it was originally developed for PTSD,
Uh-huh.
but you hear people taking it and pulling parts of it for other conditions, like in common practice. Do you is your recommendation that this is for PTSD and this is how it should be used?
That's all I've tested it for is PTSD. I mean, if people find the cognitive skills helpful for other things, that's fine, but that's not. Um, that's the treatment for PTSD is the way it was set up, and it's been tested for, we've had 40 something randomized control trials and done it in at least 7 different countries. We know that this protocol works pretty well with most people, and therapist competence makes a difference. So getting good therapy skills makes a difference. Don't
Mm-hmm.
blame the patient if you're not doing if you're not being keeping the fidelity to the protocol, and if you're not competent in doing Socratic questioning. I mean, there are some client factors like their ability to shift their thinking would make a difference. So cognitive flexibility, of course, is a good predictor of a good outcome. But I think there's a lot of therapist factors that can play a role in it, but fidelity is one of them. Now, cognitive therapy is out there and has been out there for all sorts of things. So if people take bits and pieces and use it for other stuff, they probably should be measuring and seeing how it's working for whatever it is. But don't say you're doing CPT for something else if you're not doing the actual protocol, and then you'd have to have a rationale for why are you actually doing CPT.
Off label.
Off label.
Um,
Yeah, or picking out I have heard people walk out of the room and say, I think I'll just use that one worksheet. And I say, okay, you're not doing CPT then. Don't claim you're doing CPT if you're not doing it.
and what are the how effective is the treatment? Like, how many people, when they do a good course of treatment, are going into remission or having a really significant reduction in symptoms?
Civilians, really good. Probably, I think well, you saw, I mentioned to you before on the variable length, 92% had not just lost their diagnosis, but had really good end state functioning in that study. Military and active duty don't do as well. Although this recent study doing MAST, she did very well. Like 50% lost their diagnosis. and had good and had pretty good end state. And when we did variable length, they did better in the military, active duty military, than doing a fixed 12 sessions. But there's a lot of things that interfere with being able to do it with active duty military and veterans. I think their training is not to be cognitively flexible.
Mm-hmm.
And I think there's certain things that happen during training that actually may increase the possibility for PTSD when you're taught that you are responsible for your men. Not that you're responsible to them, but you're responsible for them. So even if you're not there, if something happens to them, it's all your fault. And so they take that home and live with that. Stay alert, stay alive is posted all over the place. So like hypervigilance would be hard to fight. And so sometimes they're taught certain things that are good for going into combat. If everybody does their jobs, everybody's going to come home. Don't tell them that. You can't promise that. I understand you're trying to reduce risk by saying everybody should do their jobs, but just say everybody should do their jobs.
Their jobs.
Yeah. Do your job to the best of your ability, but no promises that if everybody does their jobs, everybody's coming home. Or never leave a man behind. Sometimes it's absolutely impossible to bring somebody home. So some of those things that are taught, and some of it is almost inadvertent. The training sergeants will say things, not necessarily the officers, but they're being trained to get ready to go into combat, and then they don't train them to come home and live in the real world, where combat is not going on. So they're still staying in their combat mode, and they're afraid to let go of that stuff. And especially if they think they're going to deploy again. I've had people saying, if I don't have my PTSD, how can I go back there? I might not have my fight flight. It's like, we are not so powerful. We are going to get rid of your fight flight response.
Yeah.
If you're in danger, you're going to react. You've been trained. We're just trying to take.
Well, even not trained, just innate survival instinct.
It's going to kick in.
Which is
We are not going to. We are in a truly dangerous situation. You are not going to suddenly forget everything you've been trained to do.
When there's someone coming in with a comorbid condition, you were talking about OCD before, and say they have significant OCD, significant PTSD, and I know exactly what you're talking about when they will merge into each other. It's almost like the obsessions, compulsions are informed by the trauma that they've had. Like they were abused and now they're having OCD around harm around their dog or harm around their children and things like that. Do you just do the standard CPT protocol and then work with the OCD after, or are you going to be doing both concurrently?
Normally we would do both concurrently because when we're doing the case conceptualization with them at the beginning of treatment, we would talk about that OCD being one of their avoidance things to make them feel calmer, that they're engaging in those things. So we would monitor that during and have them do worksheets on it and that kind of stuff. So you can incorporate it. I mean, if it was really severe, sometimes with eating disorders, they've really got to treat the eating disorder in advance, or the person's going to die while you're trying to treat their PTSD. But there's some things that tend to, at least we've got some evidence that, like for depression, that they've added some behavioral activation. Well, instead of doing it at the front end, it did better at the back end of the treatment. Same thing with insomnia treatment. We did one study down at Fort Hood, and unfortunately, I got stopped before we had a really big sample size, but the indications were that doing the 6-session insomnia nightmare treatment worked better after the CPT than before the CPT. Now, I might have guessed it would work better before because if they're sleeping better, maybe they can do the therapy better. Didn't seem to be the case. It was more like picking up the residual symptoms afterwards. There's programs that are now trying to integrate with things like substance abuse programs. They're doing more integration with the eating disorders programs, that kind of thing. I haven't seen too much on OCD and PTSD, but the ones that are the most common are the depression and about 20% are going to have anxiety. But yeah, I see there's a fair number of people with eating disorders that have trauma. So if you're starting from the eating disorder side, and then we've looked at just naturally in the population that we're working with, like when we were working with active duty military, we looked at the hazardous drinking, and there was a fair number who were doing hazardous drinking, but they were doing binge drinking on the weekends or in the evenings.
Mm-hmm.
And that dropped as their PTSD got better, that dropped. But that's not starting from a person who's got a full-blown substance abuse problem. That's, we were starting from the PTSD side. So I think we need more research that's starting from the other side, that they have this and PTSD, to see which does better. Now, obviously, if you have to go through withdrawal, you'd have to do that first.
Sure. So a lot of different considerations to take, and just like everything, research comes out over time, and we know more and more as people are looking at it.
And one study isn't necessarily going to give you the answer, and especially if you got different populations you're working with.
Okay, so we have the second edition of CPT, the new manual coming out. Any other exciting changes that we should be looking for in
well,
one
we
two?
we do now have a chapter that Candace Munson wrote on case conceptualization, to help people think through. And actually, there's a map for the therapist to think through what are their traumas, what are their main stuck points, what are kind of help them map out the possible course for treatment. Cool. So we have a whole new chapter on case conceptualization. We have more on these varying kinds of therapies. So we're talking about doing it. We have more information now on doing CPT doing it in westernized countries is they pretty much don't change the protocol. Japan's got an RCT that's coming out that very low dropout rates. They didn't have to change the protocol really. Germany didn't have to change the protocol. So some of the other westernized countries, but like if you're doing a study in the Congo or in Iraq or in Azerbaijan or someplace where you have to really change the protocol a bit, because you have to train the therapists, and the patients may be illiterate, and they may have cultural considerations. There was one study that was done that was done in the U.S., but it was done on an Indian reservation with Native women who were, I think it was mostly women, who were substance abusing, PTSD, and had HIV risk because of sexy risk behaviors. And they did CPT and found out it actually improved all of them, but it took a while to make it like a culturally competent therapy. So they incorporated some of their imagery and stuff. The alternative thoughts worksheet doesn't look like a nice grid. It looks like a mountain that you're climbing. So the ABC sheets at the bottom, and there's the questions, and there's the thought. And then it's really pretty. I like it. I like it better than the one we use. But it's kind of the image of ascending a mountain. And I thought, very clever.
Maybe they'll be in version 3.
Maybe it will be.
A mountain versus boxes. And the self-help book, who's it good for? And what can we expect if somebody buys it and looks through it?
Well, we were piloting a texting study, texting CPT. I got contacted by Talkspace, one of the texting companies. And they wanted to know if you could do CPT. So we got some grant money to study it. Now 2 other people are doing an RCT on it. But we had to come up with a manual to give to the, it's not as evolved as the one that we're now selling, but we had to come up with a manual because you can't text all the explanations for things. So series of whiteboard videos to watch, and also a more elaborated manual. And then we took it from there and thought, well, what we've been trying to do all this time is help them become their own therapists. I mean, that's the point of all this, is that you're teaching them more balanced thinking. You're teaching them to think in different ways and come up with their own alternatives. So three of us sat down and worked together over a weekend, and then finished it up over the next few weeks. But breaking it down into smaller steps. So when we're more asking them questions, asking them to write in the blanks, there's a lot of people who cannot get to CPT. Either they're too far away from a CPT therapist, or they can't do telehealth, or they can't afford it. The waiting lists are long. And so what we wanted to do is give them an alternative. There's one study that's using it as stepped care. They give them the book first and then see if they still need the CPT. That's going on in Australia right now. When I looked at Amazon, there's a really interesting set of reviews in there. It just came out last April, and they're now on the second printing. But people don't often write reviews, but it was amazing the differences. Somebody said, I used it after I got CPT, and somebody else said, use it, but make sure you have a therapist. Somebody else said, I'm a therapist, and I'm using that as the patient manual. So people were using it in all sorts of different ways. Some people just won't go to a therapist. They've got too much stigma about it. So, pick it up and try it. I mean, we're very encouraging all the way through the self-help manual about don't just stick it on a shelf, keep using it.
Yeah. And going to a therapist and feeling like you're not going to be able to control the dose.
Yeah. Yeah.
Right. Because you've been traumatized and you're not going to be able to control the dose, and that you might be forced to address things that you're not ready to address. Maybe the warm up can be doing the self-help book.
Yeah.
And then,
that's one thing I'd like to see.
I
I want to see research on this. We published it before we did the research, but it's the CPT manual, but it's made for anybody to read.
And where can people find the new CPT manual? And can you tell us the name of the self-help book again?
The self-help book is called Getting Unstuck from PTSD. And I think there's a subline. Using cognitive processing therapy to guide your recovery. And you can either go to the Guilford Press site, or you can go to Amazon or Barnes & Noble and order it through them. Everybody gets everything online these days. But actually, somebody walked into a bookstore and did see it there in a bookstore, took a photograph and sent it. But Amazon's probably the fastest, or going to the website. The new therapist manual isn't coming out till April. So that will be coming out in April, and that has, as I said, we've changed the language throughout. We've simplified some of the worksheets. We've changed the name of it, gotten rid of the whole concept of challenging, because we don't want there to be any confusion about it. We want the Socratic dialogue to be soft and gentle and helping them think through, because the answers are in them anyway. So we're just asking questions for them to realize and open up the picture and remember exactly what happened, so that they, without the blood and the guts and the gore involved, like why are they stuck? And people aren't stuck on the blood and the guts and the gore. They're stuck on, it's all my fault, or I should have stopped it, or I should have been able to save that person, or whatever.
Can people, and you might not know the answer to this, but can people pre-order the manual, or do you have to wait?
Right now through Amazon, I noticed you can pre-order it. It's going to be coming out April 11th, so it's not that long from now.
Oh yeah, I mean, it's a little bit less than done. Time gets confusing in my head sometimes. Yes, it's March.
Yes, it's cooked. It's just getting printed.
All right. So before we wrap up, any last thoughts about trauma, PTSD, cognitive processing therapy that we didn't hit on, or you want to leave our listeners with?
No, I would love to get some feedback on either of those, either the new treatment manual or the Getting Unstuck, the self-help book, because the feedback is what's helped us improve and change things over time. So anytime we can get feedback, we're happy to receive it. And we get a lot from our trainers, but it's always good to get it from people who are using it and picking it up and using it. And so.
How could people actually submit feedback? Is there a way to do that?
I think so, yeah. But I mean, they can always email me, Patricia.Resick at duke.edu.
You might have just
Well, we'll see.
opened up a huge influx
Well,
of emails.
well, I'm not going to do full blown supervision on for somebody, but feedback I'd love to get on either of those
Okay,
books.
great. Well, I mean, thank you so much for taking the time and answering all my questions. And it's been incredibly insightful. And there was a bunch of times where I asked the question and I thought there was going to be a nugget of information, and you laid so much more out there. So I really personally learned a ton about this therapy and the advancements. And it definitely filled no holes in my knowledge that I was unaware
Good,
of.
good. Glad to help. Thanks.